All right, today we have a real medical detective story for you. And honestly, the stakes could not be higher. We've got a pathologist on the case, and their one job is to unmask a dangerous-looking imposter to save a patient from a truly life-altering surgery. So let's get right into it.
So right out of the gate, here's the central conflict. On one side, you have this scary clinical threat. A patient comes in with a firm mass that, for all the world, feels exactly like a cancerous tumor. But on the other side, you have the pathological truth. It's something called a paratesticular fibrous pseudotumor, or PFP. It's rare, totally benign, and not cancerous at all. The entire goal here, the whole point of the investigation, is to prove it's innocent and stop an unnecessary radical orchiectomy, which is, the complete removal of the testicle. So, to crack this case, we've got to start at the very beginning. Let's dig in and investigate what this imposter actually is and where in the world it comes from.
What's so fascinating is that our suspect here wasn't born bad. In fact, PFP isn't really a tumor at all. It's what we call a reactive process. Just think of it like scar tissue that got a little overenthusiastic. About a third of the time, it's kicked off by something in the past, maybe an old injury, an infection, or even a surgery. And get this, it usually pops up when someone's in their 20s, often long after the event that triggered it has been forgotten.
Okay, let's move on to the crime scene. This is where the surgeon and the pathologist start gathering those first critical, tangible clues.
And the very first clue is, well, it's alarming. The surgeon finds this firm little nodule, usually on the tunica vaginalis, which is just the membrane that surrounds the testicle. And the texture is described as stony hard. I mean, when you hear that, the alarm bells for cancer start ringing loud and clear.
But then, once we get a piece of it under the microscope, the story begins to change. Instead of the chaotic, invasive cells you'd expect from cancer, we see these smooth, well-behaved nodules made of dense, scar-like tissue. This is our first real hint that maybe this isn't the villain we thought it was.
So now we're going to zoom way in. It's time to hunt for this imposter's unique fingerprints, the microscopic details that are going to give it away.
And there it is. Bingo! This is the suspect's signature move. Look at that dense, pink, glassy-looking collagen. See how it has that classic swirling, almost wire-like pattern? And the cells scattered inside look calm, or bland, as we say in pathology. This unique pattern is a massive, massive clue.
We also find some secondary evidence at the scene. You can see signs of old, chronic inflammation, some evidence of past bleeding, and if it's been there for a really long time, you might even find some calcification. All of these little clues back up the theory that this is a slow, reactive process, not some aggressive, fast-growing tumor.
But look, even with all this visual evidence, you can't take chances when the stakes are this high. We need the forensic testing, the definitive proof, to be absolutely sure we're not dealing with a real killer.
And this is the million-dollar question every pathologist has to answer. How can you be 100% certain? One wrong call, and a patient could undergo a major surgery they never needed. So how do you prove it beyond a shadow of a doubt? Well, we turn to something called immunohistochemistry, or IHC. Think of it like using special stains that light up specific proteins inside the cells. Now, some stains do come back positive, like vimentin and smooth muscle actin. This gives us a partial ID. It tells us we're dealing with the right family of cells. But, and this is a big but, these stains aren't specific enough to prove its innocence all by themselves.
And here it is, the climax of our whole detective story. The proof of innocence isn't in what we find, it's in what's missing. PFP is what we call a diagnosis of exclusion. We run tests for all the key cancer markers, ALK1, S100, keratins, all the usual suspects. And they all come back negative. That whole panel of negative results is our biological green light. It's the definitive proof that clears our suspect and stops the surgery in its tracks.
Think of this table as a police suspect lineup. Here's our guy, PFP, with its telltale swirly pattern and its non-specific stains. Now compare that to the actual bad guys. Inflammatory myofibroblastic tumor, that's positive for ALK. Solitary fibrous tumor, positive for STAT6. It's how we can definitively pick our benign imposter out from a lineup of real killers.
So, let's tie this all together. How do all these different pieces of evidence combine to let us solve the case with total confidence?
There's no single silver bullet for this diagnosis. A confident call is made right there in the middle where three key things overlap. You need the clinical story, like a history of trauma. You need that benign appearance under the microscope, and most critically, you need that rigorous panel of negative stains that rules out the malignancies. It's this triad of confirmation that finally cracks the case. And that's why all of this matters so much. It all comes down to recognizing the imposter. PFP is a master of disguise, perfectly mimicking cancer when the surgeon first sees it. But through careful, methodical detective work, combining what it looks like with what it's not, pathologists can provide the absolute truth. And that truth saves a patient from a life-changing surgery they never, ever needed. It really makes you wonder, doesn't it? How many other imposters are out there in medicine just waiting to be unmasked?